Hello everybody, this is the second session whereby we will be talking about the evening session of NEET PG question paper which had come this time. So first of all, I would tell you to please look into the first session, that is the morning session. Once you have listened to that and you have solved it, then come to the second session, because here we will be going a bit fast. So second session, the first question was Nugent score is used for the diagnosis of. So Nugent scoring, you all know Nugent scoring is used for bacterial vaginosis. Nugent scoring. So basically there are two criteria, Amsel's criteria, which is used for bacterial vaginosis BV, and this Amsel's criteria is a clinical criteria. This is the clinical criteria which we do in OPD. The second is the Nugent score. Nugent score is what the pathologist and the microbiologist does in the lab. So Nugent scoring also talks about bacterial vaginosis. So the question has come, Nugent scoring is the direct question which has come. Answer will be bacterial vaginosis. Question number 2, 26-year-old conceives on the IUCD, wants to continue pregnancy. What is the next best step? So basically when patient becomes pregnant with an IUCD in situ, so what we do is, once we have diagnosed that patient has become pregnant, we try to catch hold of the thread of the IUCD and pull it down. Catch the IUCD and pull it down. If you are able to remove the IUCD from the side, then it's well and good, you remove the IUCD. But if you are not able to remove the IUCD, or if the IUCD becomes adherent, then just leave the IUCD and let the pregnancy continue with IUCD in situ. We leave it with IUCD in situ. But of course, first we give a trial to remove the IUCD, because IUCD remaining in the cavity will hamper with the growth of the fetus, and there might be chances of FGR or fetal injury. Sometimes it may be adhered in the placenta, and there can be a bit of minimal of subchorionic hemorrhage also can be there. So always try to remove the IUCD gently. Answer will be A, remove the IUCD gently. Question number 3, twin pregnancy where one twin is older than the other twin is called superfetation. So let us talk about superfetation and superfecundation. So superfetation. In superfetation, what happens is, in 1 month, suppose this is month 1, okay, in that month pregnancy has occurred and one of the baby is there in the uterus, one baby is there. But next month there again has been ovulation. Next month or 1 or 2 months after that ovulation has occurred. Generally ovulation नहीं होना चाहिए जब एक बार pregnancy हो गया, बट अगर ओवुलेशन हो जाता है एंड दोबारा से फर्टिलाइजेशन हो जाता है विद स्पर्म एंड अनदर बेबी कम्स इनटू द यूट्रस, नाउ दिस बेबी विल बी 1 or 2 months smaller than the one twin. So one twin will be a older twin and the other twin will be a younger twin. This is called superfetation, means one fetus superimposing on other fetus when it is already in the uterus. This is called superfetation. So in superfetation, what we do is, the gestation of the pregnancy is governed by the larger twin or the mature twin. Okay, so once that twin attains 37, 38 or 40 weeks period of gestation, we go for induction of labor, and then we also give steroid cover so that the smaller twin gets delivered, and then the second twin might need NICU support also. So that has to be explained, because if one twin is delivered, then the second twin cannot maintain pregnancy because the placenta may be extruded out. Okay, so this is superfetation. There is another concept called superfecundation. So what actually happens in superfecundation? In 1 month only both the twins have formed. Okay, so fertilization has occurred. But the thing is that one fetus, fertilization has occurred from sperm of one male, whereas there has been another ovum. 2 ova were released. One ova was fertilized by one male sperm and the second by another male's sperm. So if there are 2 acts of coitus in the same cycle, now this 2 acts of coitus can lead to 2 fetuses forming at the same time, but from 2 different fathers, then it is called superfecundation. Or sometimes it may so happen that both the fetuses are from the same father, but the act of coitus will be different. Okay, act of coitus has to be different, then it is called superfecundation. Otherwise it will be a general fraternal twin or dizygotic twin if it is from the same father and through the same coitus. So where one twin is older than the other, answer will be B, superfetation. Question number 4. 30 years old woman presents with cervical elongation. Her family is complete. What is the preferred surgery advice? So basically the preferred surgery advice will be Fothergill's operation. This is because whenever the prolapse is because of increased length of the cervix. So if the cervix is elongated, then what we do is we generally go for cervical amputation. We cut and remove this part of the cervix. Cervical amputation followed by joining of the corpus with the side walls, that is your Mackenrod's and uterosacral ligament. With that tying this part of the body is called nothing but Manchester operation, Manchester, or Fothergill operation, Fothergill. This is because Fothergill was the first surgeon who had done it, and he had done it in Manchester. So Manchester Fothergill operation is done. Okay, so answer will be A, Fothergill. A young woman presents with prolapse. Mesh is being placed. What is the area in which the mesh is fixed? So basically when you fix a mesh, it is the sacral promontory. It is the sacral promontory at which the mesh is fixed, and then to the cervix. Okay, so it is also called as colposuspension. So this is because the sacral promontory is an area which is a fixed area, and there you can place the mesh. So answer is very easy. You fix it to the sacral promontory, answer C. Identify the maneuver. This is a very easy maneuver. Question number 6, Byrne-Marshall method. All of you might be knowing. Byrne-Marshall method is a technique used for delivery of the head of the, this time we had 3 questions from breech. Okay, first question is this, Byrne-Marshall method. So the picture shows the head delivery by a long arc of extension of the baby. The second question is also there. Identify the delivery of the aftercoming head. So what is the instrument which is used? Piper forceps. B is Piper forceps is used for aftercoming head of breech. And the third question of breech which came is question number 9, which you can see is that which of the following is a contraindication, which is not a contraindication for the procedures shown. So you can see this is an external cephalic version which is being done. With your hand you are doing an external cephalic version of a complete breech. So what are the contraindications? Of course, placenta previa you will not do, because after, if it is placenta previa, then there is no chance of vaginal delivery. Answer C, multiple pregnancy is also a contraindication, because if there are more than one fetuses, then external cephalic version will not be possible. And in D, ruptured membranes, already rupture of the membrane has occurred and there is no liquor, so ECV cannot be done. And answer B, primi gravida will be the answer, because primi gravida is not a contraindication for external cephalic version. Coming to question number 8, patient experiences softening of the cervix. What is this sign called? Always remember Goodell sign. Goodell sign is the sign which is the softening of the cervix. At the same time, I would also like to tell what is Chadwick sign. Chadwick sign is bluish discoloration of the vagina, is called Chadwick sign, which is seen in pregnancy. Osiender's sign is the Osiender's and Hagar's sign are also seen at 6 to 8 weeks of pregnancy. These are the signs whereby you try to look for whether the lower uterine segment has become soft or not. So there is a bimanual examination which is done. Bimanual examination is done. And the bimanual examination will help us. In the bimanual examination, basically one hand goes to the anterior, the posterior part of the cervix, and with the other hand, it will be the abdominal hand, you will try to palpate. So you will try to palpate from above and below the uterus, and there is ballotment present. So this is called the Hagar's sign. This is seen in pregnancy. These are the probable signs of pregnancy. Coming to question number 10, Gravida 3, Para 2, Live 1 and 1 neonatal death. NND is neonatal death with previous 2 LSAs and primary HSV, that is herpes simplex virus. The mode of delivery will be cesarean section. Always remember, primary herpes simplex virus is very contagious, and you never go for normal vaginal delivery if patient is having primary HSV infection. All the more this patient had a previous neonatal death, bad obstetric history, and previous 2 cesarean section. So there is no chance of giving a VBAC, because VBAC is allowed only for previous 1 cesarean section according to ACOG. I have already taught. Coming to question number 11, implantation of the embryo takes place how many days after fertilization? So basically implantation occurs after 5 days of your fertilization. So when the ovulation occurs, okay, at day 2 to day 3 the fertilization occurs, and if you take this as day 2 to day 3, then at day 8, day 7 to day 8 the implantation occurs. So the timing is from fertilization to implantation, it is almost 5th day. Okay, 5 days. So 8 minus 3 will be 5 days. So answer will be 5 days, B, 5 days. A patient presents at 10 weeks period of gestation with at 10 weeks she asks for medical method of abortion. What will you advise her? So you all know mifepristone and misoprostol are the drugs of choice for medical management of abortion. So this is a very easy question, very straightforward question, nothing to think about. The only glitch here is that Government of India allows this medical method of MTP up to 9 weeks. But don't get confused, even if patient comes to you at 10 weeks also, WHO allows till 12 weeks you can go for mifepristone and misoprostol. Even beyond 12 weeks also the method of choice will be mifepristone and misoprostol only. What are the tumor markers which are done if a patient is having complex ovarian cyst? Now you can see this is a complex ovarian cyst. So basically what happens, let us talk about complex ovarian cyst. So you all know whenever you have ovarian cyst, we go for RMI scoring. RMI scoring consists of your menopausal status, your ultrasound features, and your CA125. So CA125 is a marker of epithelial ovarian cancers. In ultrasound you have 5 features. I have already spoken this earlier also. This has a mnemonic BAMMS. Okay, BAMS. So B is bilaterality. If a tumor or an ovarian cyst or ovarian mass is bilateral, it is more chance of having malignancy. If there is ascites present with it, then more chances of malignancy. M stands for multilocularity. Multilocularity means if there is internal septa present and it is divided into 2 or 3 parts, if it is a multilocular cyst, then chances of malignancy is more. Then M stands for metastasis. If metastatic lesions are there, then chances of malignancy is more. And S stands for solid areas. Okay, if these features are present, then there are more chances of having malignancy. Now you can see this figure, there is a multilocular cyst because you can see a solid area or a septa which is dividing it into 2 parts. So it is a multilocular cyst. So more chances of having malignancy. So if you are thinking about malignancy, what are the tumor markers which you will be doing? Number 1, you will be doing a CA125. CA125 is a marker of epithelial ovarian cancer. So if epithelial ovarian cancer is there, then your CA125 will increase. Number 2, you will do CA19-9. CA19-9 is a marker of your mucinous tumors. Okay, mucinous cancers will have CA19-9 raised. You also do a CEA for the patient. CEA is carcinoembryonic antigen. It rules out any GI malignancy. So secondaries from the GI tract can be ruled out with CEA. Also you get beta HCG done, because beta HCG, your LDH, serum LDH, this lactate dehydrogenase, and your alpha fetoprotein, these are markers of germ cell tumors. Because the age is not high, this patient is a low age patient, so germ cell tumors can also be done. Beta HCG talks about your choriocarcinoma. Okay, non-gestational choriocarcinoma is present in beta HCG, will be raised. LDH is a marker of dysgerminoma, and alpha fetoprotein is a marker of yolk sac tumor or polyembryoma. polyembryoma. So basically these markers, these 6 tumor markers we get done. This is the panel of tumor markers which helps us in differentiating what type of probable cancer is there. Based on that we go for the surgical management thereby. So these are the tumor markers which are done. Next question is, following delivery at a PHC, a patient was referred following this image on the examination. What type of tear is it? You can see the vagina and the rectal canal or the anal canal has become one cavity because the perineum is completely torn. So let us talk about OASI. What is OASI? OASI is obstetric anal sphincter injury. Obstetric anal sphincter injury. A very important terminology comes in Viva also. What is OASI? Obstetric anal sphincter injury. So perineal tears after delivery can be divided into first degree, second degree, third degree and fourth degree perineal tear. First degree perineal tear is when the vaginal mucosal tear occurs. Vaginal mucosa is torn. सो दैट इज़ वेरी ऑब्वियस. कोई भी डिलीवरी होता है, इफ़ देर इज़ प्रॉपर अगर सपोर्ट नहीं देते हैं तो वेजाइनल म्यूकोजा टेयर होता है. तो दैट इज़ फर्स्ट डिग्री पेरिनियल टेयर. सेकेंड डिग्री पेरिनियल टेयर इज़ व्हेन वेजाइनल म्यूकोजा प्लस पेरिनियल मसल्स are also torn. Perineal muscles are also torn. So perineal muscles consists of your bulbospongiosus, ischiocavernosus, superficial transversus perineum, deep transversus perineum. All these muscles get torn. Now remember, iatrogenically induced second degree perineal tear is also called episiotomy. So basically when we give episiotomy, we are making a second degree perineal tear because we are cutting the muscles of the perineum as well as we are cutting the vaginal mucosa. Okay. Category 3, that is the third degree perineal tear, can be divided into 3A, 3B and 3C. 3A is when there is less than equal 50% of external anal sphincter which is torn. So now besides the perineal muscles, now the anal sphincter, that is tear, is going more and more towards the rectum or the anal canal. So less than 50% of the external anal sphincter has been involved in 3A. 3B is more than 50% of external anal sphincter is torn. Whereas 3C is external anal sphincter पूरा तो जाता ही है, साथ में internal anal sphincter has also been torn. Whereas 4th degree perineal tear is when after and above that anal mucosa is also torn, and once the anal mucosa is torn, vaginal cavity and rectal cavity now becomes one cavity. Okay, so now patient urinates and defecates from the same opening. This is a very pathetic condition. So this is what is shown in the picture, and they have asked you what type of tear it is. It is 4th degree perineal tear. So repair will be, you have to repair it layer wise. First you will repair the anal mucosa, then you will repair the internal anal sphincter, then the external anal sphincter, then the perineal muscles, and then the vaginal mucosa. So similarly, in the first 48 hours, if you diagnose, then you stitch it. Otherwise, you stitch it after 3 months, 6 weeks to 3 months, okay, because inflammation will be there. Now, this patient LSCS was done for breech. Intraoperatively, you find that 2 uterine cavities are present and 2 cervix is also present. So 2 uterine cavities can be a bicornuate uterus as well as a diadelphys uterus. But since the question has told 2 cervix is also present, so this is a uterus diadelphys. Answer will be A. A very simple question. Coming to question number 16, a patient comes after 6 months of vaginal delivery with an episiotomy repair and pain at the site of episiotomy, and this pain characteristically increases during her periods. Okay, so this pain increases during her period, so the answer will be endometriosis, because any pain increasing during the periods means it is adenomyosis or endometriosis. Of course, if the pain is in ectopic areas, somewhere other areas like the episiotomy site में endometrium कोई tissue रह गया था जो हर बार bleed कर रहा है and it is causing pain, so it is scar site endometriosis or episiotomy endometriosis. Question number 17. The most common site of tubal ligation is of course isthmus, because we do this thing in the isthmico-isthmic junction. If this is your tube, okay, then what other areas? How do we say? Mnemonic hai IAS and repeat I. IAS and repeat I. This is the uterus. I stands for your infundibulum. Infundibulum. A stands for ampulla. Ampulla is the most common site of fertilization. S stands for isthmus. Isthmus. And I stands for intramural part. Intramural part. So these are the parts of the tube. So isthmico-isthmic junction is the thinnest part or the narrowest part of the tube, and this is the area where we do go for tubal ligation, whereas ampulla is the site of fertilization. So this was the question. Where you do, answer will be B, isthmus, because this is the narrowest part of the tube. Coming to question number 18. A 40-year-old woman presents with heavy menstrual bleeding and something coming out of the vagina. Okay, so heavy menstrual bleeding, AUB, with something coming out of the vagina. Last child was 10 years back. Bimanual examination, uterus is palpable. तो यूट्रस तो अंदर ही है, पेट के अंदर है, तो प्रोलैप्स नहीं है and there is no uterine inversion, but something has come out. Now on examination, cervix admits one finger, so cervix is open. So probable diagnosis will be either a submucosal fibroid which is coming out, protruding out, or a fibroid polyp. So answer will be B, fibroid polyp. Obviously it will not be an intramural fibroid, because intramural fibroid अगर बाहर आ जाएगा तो पूरा uterus ही बाहर आ जाएगा. Patient will, uterus will not be palpable. Adenomyosis cannot be there because uterus is palpable. Okay, so basically it will be a fibroid polyp. Treatment of gonorrhea is always cefixime. This is because gonorrhea is a gram-negative coccus. If you remember, gram-negative coccus. There are two gram-negative coccus. One is Neisseria gonorrhoeae, and Neisseria meningitidis. If you remember your microbiology days. So Neisseria gonorrhoeae has back-to-back arrangement, whereas Neisseria meningitidis has comma-like arrangement. Okay, so these are very important. Okay, so the drug of choice is cefixime. 25-year-old woman presents with primary infertility found to have bilateral tubal block on HSG. The next best management. So whenever you do HSG and you find that both the tubes are blocked, both the tubes of the patient are blocked, dye is injected through the Leach-Wilkinson cannula. Leach-Wilkinson cannula is used for putting the dye, but still you find that dye is not coming out, there is block on both the sides. So the most common cause of blockage of bilateral tubes is tubal spasm. Tubal spasm occurs because patients have a lot of pain. So the next management is under general anesthesia. Okay, when patient is not having pain, go for laparoscopic chromopertubation. Pertubation. What do you mean by that? You put methylene blue dye from inside and put a laparoscope outside in the abdomen and try to look whether dye is being spilling from both the sides. Most of the patients who have bilateral tubal block in HSG will have dye coming out in laparoscopic chromopertubation, and so their cause of infertility will be ruled out. So answer will be A, laparoscopic chromotubation. Next question is a similar question which had come in the morning session. Magnesium sulfate toxicity are monitored except. So I have already told respiratory rate is seen. If it is less than 12, then we stop magnesium sulfate. Urine output less than 40 ml per hour, or 100 ml in 4 hours, or less than 30 ml per hour can be warning sign where you stop the magnesium sulfate. Deep tendon reflexes if absent, then also we stop, but routine magnesium serum levels are not done generally. Next question is a cogwheel appearance on ultrasound is very important. Cogwheel appearance is a sign of cogwheel appearance in ultrasound is a characteristic sign of hydrosalpinx. Always remember, very important, hydrosalpinx. Whereas at the same time, I would also like to tell the signs of genital tuberculosis. Genital tuberculosis in the uterus, you have Asherman syndrome. You have Asherman syndrome in the uterus, where there is honeycomb appearance. In the tubes, you have beaded appearance of the tube can be there, which is called salpingitis isthmica nodosa. Salpingitis isthmica nodosa, very important, salpingitis isthmica nodosa. Apart from that, you have very thinned out tubes. You can have lead pipe appearance of the tube. You can have leopard skin appearance of the tube. You can have other types of things like your tobacco pouch appearance of the fimria. Okay, tobacco pouch appearance of the fimbria. So these all are specific for genital tuberculosis. These can also be coming. The last question is of the day: after ovulation, the egg is arrested in, always remember, secondary oocyte is arrested in meiosis 2. This is because the meiosis 1 occurs at the time of when the ovaries or the eggs are being recruited. At that time the first meiosis occurs, but then the second meiosis starts and second meiosis gets arrested, and the second meiosis completes after the fertilization occurs. After the fertilization occurs, then only one polar body is being extruded and the secondary oocyte is formed. Primary oocyte is formed before puberty. Okay, secondary oocyte is formed at the time of fertilization when the second polar body is extruded. So after ovulation of the egg, the answer will be D, secondary oocyte is arrested in meiosis 2, which is completed after fertilization. So this is all about the evening session. I hope you have enjoyed it. Questions were very easy this time. I hope people will be doing very good. Both the morning and the evening session were very easy. Morning session was comparatively more easy. It was easier than the evening session. I hope you all will also do well in your NEET exams. I will try my level best. Whenever you have any doubt, do try to call me up and disturb me. I don't get disturbed. So all the very best, and thank you for listening to me.